run into that?
Yeah, it's
More with ovarian especially, and you're kind of left with, oh, this is a mess, and I don't see any really dilated loops. Do you use wall thickening? I mean, is there anything else you could hang your head on besides?
Yeah, good question. I'm glad you asked. The loops often look matted together. The wall thickening is not in the form of submucosal edema, which is the most common level of and cause of bowel wall thickening. They look clustered, and I've got a low threshold for calling that. When I see that in a patient with a GYN malignancy, or maybe in a man with a GI malignancy, because I've had this experience so often, and honestly, I've had such a positive response from patients and patients' families and their doctors, who feel like somebody has finally given them an explanation for understanding why this patient has these symptoms of bowel obstruction, even though we don't see dilated bowel loops per se.
Okay, thanks, Mike.
Yeah.
Another question? You.
Yes, I have a question for Dr. Coakley. I recently read the 25th CT scan on a 35-year-old patient in 2 years for left flank pain, all was negative, including the one that I read. And, attempting to have a conversation with my ER colleagues about these kind of things could be seen as obstructionists. Have you ever had any insight into how to have this kind of talk with our emergency colleagues about this issue without coming across that way? Because you're getting to the range where I'm presuming that this is certainly a high radiation dose. And I just didn't know if you had any experience or insight in that regard.
I know Rebecca Smith-Beineman did a study on this exact issue and was actually suggesting we should be pushing for ultrasound more in these recurrent flank pain patients.
Yeah, I'm sorry.
Oh, I'm sorry, yes. So the question was what to do with the flank pain patient who has multiple recurrent CT scans, and apparently the specific question said they'd seen someone who had 25 such negative studies. Other than hopefully, and then the question was how to handle that with the emergency room. I think hopefully you could engage, the quality leaders in the emergency room to try to get them to discuss that, because there is literature on what to do, and they really should hopefully be looking at the prior negative record and maybe when we have better decision support that sort of pulls out that information, and maybe a warning box flashes up that this patient has had multiple negative prior CTs for this issue. Maybe you might think about ordering another one. Mike, you wanted to...
I feel really strongly about this issue. I do a lot of lecturing at meetings like this, and did in New York last week. And the question I get every time is, are you troubled by this increasing trend towards doing non-contrast CT scans for everybody coming out of the emergency room? I actually think it's a crisis. In their literature, there's all kinds of total crap, and I don't care if this is being recorded. You can put that in the recording. They use it for everything, unthinkingly, and they've got this vision that somehow giving IV contrast, first, I think they don't really understand the difference between giving oral and giving IV contrast. Giving IV contrast does not delay emergency room throughput. And I have seen so many missed lesions coming out of the emergency department, largely because we're looking at a crappy, relatively low dose CT scan, often at fairly thick sections, and we're just missing images. Elliot showed a half a dozen things there that you can miss on non-contrast CT scans, but I'm seeing it over and over again. And I think we need, as an organized radiology group, to attack this, because they say, hey, look, our organization of emergency physicians supports this, doing non-contrast scans. I think it is horrible.
Yeah, just to follow that up, right, there have been several articles, and I should have memorized this article. The article goes like this: radiologists who are trained to give contrast, and we know better. And it's all in the ER journals, and it's the president of the ER Society. We put a lot of effort in Hopkins on that, because non-contrast studies are good for stone disease. Stop.
Period.
That's it.
Period.
Beyond that, you're looking for whether it's the kidneys with the infarcts, the infection, and everything else, whether it's the pancreas, whether it's the bowel, whether it's focal dissections, particularly in an era when CT is so good, where the one article from Mass General looking at the ER setting roughly half the time it changed the diagnosis of what was suspected. So even with the best ER docs, they're still not going to get it right. And the CT with contrast is what gets it right. I think there's no doubt in terms of having too many studies. There's some point where, okay, that seems to be crazy to get that many studies. There's no doubt, and you need to do ultrasound. But yeah, I think we do a tremendous disservice. I fight it out at Hopkins too. After all, if you argue enough, you can get them to give contrast, but it's this tremendous thing. And also, they don't know what contrast means. It's kind of like, okay, so we give oral contrast to all patients. Okay, that's because of me. We give oral contrast. Now, I'm not saying we give positive contrast because water is oral contrast. Now, I have explained to the ER that we don't give water because it's oral contrast. We give water because you give IV contrast and it decreases the chance of nephrotoxicity. So they think, oh my God, we don't give any oral contrast at Hopkins, we give water. So it makes no sense to me because in the sense, you're doing a patient with abdominal pain and then the stomach is not distended. So you look at the reports and it says stomach can't be evaluated, rule out, or the stomach is infiltrated, recommend endoscopy when it's normal, or the stomach is probably normal when there's no way you can say it's normal or not. It's just like sheer madness. And the thing is, CT is really, really good for the stomach. And I'll think of the GI bleeding talk, I'll show some gastric cancers where you pick up a GI bleed in the stomach, that endoscopy was negative. So I think you need to, do the right amount of studies in the ER for the right reasons, but when we do them, it needs to be done correctly. And I think organized radiology, there's been a few editorials here and there about that. In emergency radiology, there was something, I think, in JACR. Dushyant, what do you think?
I mean, so you all touched on a very important point that CT is the new stethoscope for ED, and, it's so efficient. Getting a CT is much quicker than even getting an ultrasound. I think some education is critical, not only if IV contrast is the best thing, because they have these weird concerns, and I think it's lack of knowledge about the risk of IV contrast media and then, ultrasound also, we should have a mechanism where we can facilitate this in a timely fashion, because the resident or a fellow who is ordering is pressured to move patients in and out of ER faster. So they will do anything to make that happen.
Right, but as you know, usually what happens is this, and I always make the same statement. The patient waited 6 hours to get the CT. Now you're going to blame the 3 minutes in CT why they were 6 hours in the ER. No. It only counts the last 3 minutes that we were doing something. Because all of us, every one of our institutions and your institutions is very efficient in the ER setting. You get the patients in and out, but if they don't get to you for 6 hours because they're twiddling around, it's a problem. Mike?
So I wanted to change gears, if I might, and comment on one of Fergus's points, a couple of them actually, and that is the TSTs. I really, really try to avoid that in the liver and renal lesions. And I think that we really can. For one thing, you're acquiring images at much less than 5 millimeter thick images. And we actually never read the axial images at less than 5 millimeters, or at more than 5 millimeters. We always look at them at 2.5 or 5. Your techs have acquired them even thinner, right, like 0.65. And when you have a too small to characterize lesion, you can ask them to show you the thinner sections, and you can take a lot of those lesions that you'd be calling TSTs and see the definitive fat for an AML, or see that it's really water density. In the liver, which am I doing it? Yeah, I am doing that this week. You're going to see a lot of lesions that you've been calling TSCCs in liver, and I'm going to tell you what they really are, and you can do it on a CT scan. Changing gears once again, I think Fergus and I have a little different threshold when it comes to what is real enhancement. I know he showed a lesion that was presumably a papillary renal cell carcinoma that enhanced by only 12 or 15 Hounsfield units. I think that if you get a big enough region of interest and truly sample the same area, I don't think I've really seen a solid renal neoplasm, including papillary, enhanced by less than 20 Hounsfield units. I've seen a lot of pseudo-enhancements of 15 Hounsfield units. So my threshold's a little different. I'm sure there's some overlap where I would have screwed up with my criteria, and maybe Fergus would have taken a more aggressive approach than necessary with his criteria. But just to report, I do it a little bit differently there, or I use slightly different criteria.
I bet in practice we'd end up sending those
I think we probably-
same sort of iffy cases for further workup, which I think is what they would need. Yeah.
I'll just make a comment there. For me, 20 Hounsfield unit makes me confident. Under that, I look at the coronal and axial images. If they look suspicious and I feel it's in the threshold, I might do something, even starting as ultrasound, not necessarily MR. You know?
Right. So,
And I would mention one other thing. I don't think you did mention this, Fergus, and that is when it comes to, if I have a lesion that I'm inclined to call a Bosniak 2F, a mildly complex cyst, and frankly, I'd be willing to just write it off with nothing else. And one of my colleagues, if he's the primary reader of it, the younger guys, they want to get an MR. Okay. Invariably, the MR makes it look more complex. And then they go, oh shit, now I'm worried. I guess we're on recording. Okay, we're going to need an editor for my part of it. Now we're more worried. Now it's a Bosniak 3. Now we got to do a partial nephrectomy. And for years I've been saying, you know what, guys, I've never seen one of these that you have upgraded beyond my Bosniak 2, don't worry about it, that really turned out to be a tumor. And it has subsequently come out in 2 articles in the literature that they had exactly the same experience. So I am not great with MR on the slightly complex cystic lesion being a good deciding modality. It's great for some of the other things that you showed, the lesions that you're not quite sure if it's a solid or a cystic lesion. It's great for that, but that's my own take on it.
I would second that, and it's important to remember people sometimes use Bosniak for ultrasound images, and it's only ever been validated and was started on CT. I mean, that's the only place we should probably even be using those terms.
yeah. So let me just, Fergus, because someone at home has a question. Okay, with the split bolus technique, does the residual cortical enhancement from the early bolus affect the density/visibility of the arterial phase lesions?
I mean, I've not had a problem with it because it's only 40 cc's, so I feel like that's probably largely washed out by the time we give the bigger 110 cc bolus. But I mean, what do you guys do at Hopkins, Elliot?
See, I don't like that. You know, the truth is, when you look at most of the articles on split bolus, they always seem okay. Then at the very end, is that the next to the conclusion paragraph says, we've not compared it with the regular studies, so we don't know the accuracy. Every single, you know, and I do worry about, like Mike's talking about, the small renal cells, that you could blow by them. They become isodense, you know, these 1 cm vascular lesions. The other thing, going back to the other comment about too small TS to classify TSTC, you know, I see a lot, this is being, maybe it's an old person's issue, with some of the junior people, they say, with a liver, advise MR. I've never seen MR on a TSTC come up with an answer besides advise ultrasound or advise follow-up. And sometimes I say to people who say that too often, I say, well, the issue is, I also notice your TBTC, too big to classify lesions. You got to be careful. You may be classifying nothing. So you really want to be very careful. Dushon, let me ask you, okay, you had a comment? Go ahead.
Comment on
Go ahead.
You know, I think one is now with the new CT technology like Dualenergy CT that I'll discuss tomorrow, increasingly those indeterminate lesions which we had in the past the numbers have gone down. People are way more confident in characterizing, and we have a reverse actually referral pattern now. On MR ever, they have indeterminate lesion, they order Dualenergy CT. It's like because the images are so clear and sharper. Second point on the Hounsfield unit, I want to caution everyone that Hounsfield units are highly dependent on your KVP. Most of the literature on Hounsfield unit is on 120 kVp, and all the new technology, because there is KVP selection software, it's going to 100 kVp or 80 kVp. So one should factor that when you use Hounsfield unit threshold ever, because at lower KVP the numbers will be higher.
Yeah, good point.
That's a great point. Also, it's for people who have multiple scanners. You know, at Hopkins we have 1 scanner, so I really know roughly what's going to happen on each patient. I don't need to think about it. But if you have a Philips and a G and a Siemens, or you're looking for multiple sites, often those numbers don't work the same from site to site. So that's a good point.
Which is another point. I get this. I had it last week when I was lecturing. Somebody said, well, I know sometimes you need to look at non-contrast and enhance, but if somebody had a contrast-enhanced CT scan of a renal mass, can't I just do a non-contrast scan at my place and compare it and determine what the enhancement was? Don't do that. There are so many variables there in terms of the calibration of the machine, the section thickness, the KV, and everything else. Too many ways to really screw up. So I would strongly advise not to do that.
There's at least 50 ways to not. Okay, anyway, it's 12 o'clock, so it's lunchtime. I appreciate the panel, I appreciate the audience, and just to let you know, so we're breaking now. We'll start up again at 1 o'clock, and have a great lunch. There's a place down the hall, there's places downstairs. If you just want coffee, there's Starbucks. A lot of cool places. There's also on the first level, when you come in, when you register, they had one of those machines. Usually you see Coke machines. They had a machine for champagne or something. What was it? It's worthwhile taking a picture. Anyway, have a great hour. Okay, very good. Okay, that's that.